people will remember a story. So what we like to do in negotiations is have a clinician tell a story, a patient story. And it's really powerful. And reps remember those kinds of things. I remember those kinds of things. I remember being a client, a mental health provider that provides healthcare to women who are postpartum. And I walked into the office and I was supposed to meet with the CEO, and the CFO greeted me. And the CFO said, "I'm so sorry. She's not going to be able to meet with you today because a mother was just about to step in front of a train. And so she is triaging her. We're going to get her inpatient, and she is dealing with that." And I'm like, well, heck yeah, she is. And this is I'm just like so honored to be working with an organization that does this kind of work. So I will never forget that moment. So, I mean, we're all like that. It's the emotional stuff that really, for us, it ignites action.
Welcome to Medical Money Matters, the podcast where you can find experts, answers, and resources so that you can achieve mastery over the financial and business aspects of your practice.
Hello, everyone. Welcome to Medical Money Matters podcast. I am delighted to be joined today by Doral Jacobsen, CEO of Prosper Beyond, a national consultancy that focuses on insurance contracting for medical groups. Doral actually started her career in the physician practice space in revenue cycle, and she has several years of experience working on the payer side, and now brings that expertise to bear for her clients in negotiating with payer. And prior to starting Prosper Beyond, she also operated a high-risk OBGYN group, so she understands all facets of practice management and contracting. She is the author of Transitioning to Alternative Payment Methods, a guide to next-generation payer contracting, which is available on Amazon, and we will put the link to that in the show notes. And she and her group at Prosper Beyond currently serve physician groups all over the country. She is a frequent speaker at regional and national conferences, including that she conducts an annual payer contracting webinar series in conjunction with MGMA. So Doral, welcome. Thanks for being here today.
Thank you, Jill. Excited to be on the podcast, and wonderful always to talk to you.
Likewise. Thank you. Well, let's jump right in. I know our audience is going to be excited to hear from you. And I would love to just start with understanding from your perspective, what are the most important aspects of successful contracting strategy for a physician group?
That's a great question. I think I'll answer it in a few pieces. I think the first is to make it part of your strategy. You know, oftentimes when we have strategic plans on the practice side, we do not include payer contracting. And if you think about it, it's a huge disconnect, because where does our money come from? It comes from the payer side. So that is often a miss. So I think the first piece is just to actually incorporate it into your strategic plan and normalize it. It really should be an item on the agenda that's discussed on a routine basis, because it is that important. I think the other piece is identifying a responsible party on the practice side to own it. What we often find is that we get a call and it is something's happened. You know, a payer has done something, reduced a rate, or has excluded someone from a network, and all of a sudden it's illuminated that, well, we don't have a strategy. We don't know where our contracts are. We're really not sure what we're supposed to be paid. So, yeah. So the other piece is having an identified owner of really who is going to own this for us. Make sure that we know how we're getting paid, have our executed agreements, understand the rhythm, and also, monitor everything from a contracting perspective. I think the other piece in terms of importance is really identifying what it is that you want to do from a long-term and short-term perspective. Because There are lots of things that you can do in a negotiation. Everything is negotiable. I mean, that's what we say at Prosper Beyond. People are like, can we negotiate that? We're like, we can try. And we are successful in spaces where many times our peers are not for a number of reasons. And I think it's just that attitude that if you're not sure if it's negotiable, that means it's worthy of a discussion. So I think also kind of opening up and being creative and not feeling disempowered from the get-go. Those are some of the most important elements. Great question.
Fantastic. Well, that probably leads us nicely into talking about what are some of the greatest pitfalls that you see with groups when they're doing their contracting.
Yeah. So the biggest pitfalls, there's a couple. One is folks will have a poor relationship with a payer. There's some bad blood. There's a misunderstanding that's happened. Perhaps they exited an agreement and now they're back in an agreement and it didn't go so well. So they don't feel like they have relationships. And I mean, you know how it is. Someone emails you who you might have not the greatest history with, and it might take a while to answer that email. So those relationships, if they're not in a healthy space, can impact the ability to, move forward in negotiations. I think another pitfall is time. I mean, simply, administrators have such limited time. So, we're asking someone at a practice that literally is working ridiculous hours in the first place to then take a very complex project on that. Not only is it complex in and of itself, I mean, you have to understand rates, you have to understand payment methodology, you have to understand contractual language, you have to identify who to talk to, you have to communicate with them, you have to make a case. I mean, all of these things, it's a giant lift. And on the payer side, it's not easy to even get in contact with folks on the payer side. So it is really easy. And what we see a lot of times is that folks will start the process and then they'll simply give up. Yeah. Because we just, the pitfalls are that it's not easy and we don't have enough time to do it. And another pitfall that we commonly see is it's just at the bottom of the priority list. So it's something that intellectually we know we need to address, and it makes sense for us to go back to the table. However, there are more pressing matters.
Yeah.
I mean, you can name 1,000 of them that are right in front of you. Recruiting a physician, standing up a new satellite office. I mean, all of these things. So we liken it to hypertension. It's the silent killer. It's the thing that, well, I'm really thinking about, but as time goes on, we know that our expenses on the practice side are ever increasing.
Yeah.
We have inflation that we're dealing with, and payer rates are either, if they're stable, that math is never going to work. And then many times they are tied to Medicare, and that is decreasing.
Yeah.
So it's going like this. It's just, it's never going to work. So those are some of the major pitfalls. I could go.
Well, you and I have both sat in that clinic administrator chair too, and we know that those sort of long-term important strategic tasks frequently, they get shuffled to the bottom of the list because of the more urgent day-to-day, whatever's the fire burning most brightly in front of us.
Right.
Yeah. Well, that's a great segue to talk about what kinds of major trends you're seeing in the industry. So you're working with clients all over the country. So what are you seeing? What's happening out there?
Well, we are seeing a lot of value-based and performance-based contracts, which are wonderful and also complex. Many, it just depends on the payer and what they're asking, but we've got to really assess whether or not the juice is worth the squeeze. I mean, there have been times when we've had a deal on the table, but the effort required to obtain those dollars, it just didn't make sense. So we had to pass.
Yeah.
I think it's important to give feedback to payers so that they understand this is why this is not going to work. We'd have to hire an FTE. That FTE is going to cost X. We could possibly get, if we knock it out of the park, Y.
Yeah.
And we can do it. So we have to work together, and giving each other feedback is really important. We are definitely seeing a lot of performance-based agreements. Another trend that we are seeing, and this is interesting, is a lot of folks are in IPAs or clinically integrated networks, or they're belonging to really these aggregators that hold the contracts. So they don't have a direct contract with the payer. And while a long time ago, many of the value in that was credentialing, many years ago, credentialing was a lot more complex. We didn't have CAQH. And so they were delegated. So it kind of made things easy. The network product contract, you had a contract. Now what we're seeing, we have many, many clients that are unwinding from these networks for a number of reasons. One is they can get the same rates or even better on their own.
Yeah.
And they have, if it's not clinically integrated, you cannot get those value dollars. So going direct gives you access to additional dollars. And also lack of transparency. I have a group that we're helping right now where the network withholds 15% of every dollar that they're distributing to the group, and they get all the value-based dollars. This is a big primary care group.
Okay.
So, and they have no idea how much money the network is getting, how that is distributed, and they are the largest primary care group in this network. So you can see that just does not feel good, because they're the one bearing the burden. They're the ones doing all the work, seeing the patients, adding the CPT codes to the claim, doing all of those things. So they're unwinding. They're going direct with the payer, and they are getting all of that in a bag of chips. So, yeah. And so it's interesting how you just have to really understand the value and not make the assumption like we do. We think, oh, they're going to get better rates. That may not be the case at all. They might not even be able to negotiate rates, period. So you just have to really understand, what is it that you're getting, and is it worth it? And would it be better for you to have a different arrangement with the payer or more direct relationship? And what we find, payers really like that. And it's kind of just cutting out the middleman that might not be adding a lot of value.
Yeah. Great. Well, it's a wonderful point. And I like your term aggregators, that kind of wraps arms around all of the different types of entities that are out there doing these contracts. And it is very easy to fall into that assumption that, if I'm part of a bigger thing, it's always better for me. And to your point with your client, sometimes depending on your size and the relationships within the market, that's a great point. It could be better to be on your own.
Absolutely.
That's great advice. Well, so I'm curious to hear from you a couple of horror stories. I'm sure you've heard some, and hopefully our audience won't hear themselves in your stories, but maybe help them prevent being one of those.
Oh, yeah. So many of our contracts have language that say a payer can amend a contract just by notice, meaning they can send you a letter and they can say, we are amending your contract, we're adding a product. Most of the time they're updating a fee schedule. Sometimes that's not a good thing. I had a client recently where they were decreasing his practices rates by 30%, major payer, big deal. Now, it just so happened that we were approaching that payer to renegotiate the contract. So we found out about it. They had 30 days to react to that letter. Yeah. So we were able to terminate that agreement. So that worked out okay. But that was just luck. It really was, because here's what happens is that letter goes to who knows where.
Emailed from 3 administrators ago, most likely. Yeah.
So it depends what's in the payer system, and a lot of times we don't know. So the horror story is we have clients a lot of times that will send us this letter after that period. And so there's nothing they can do. They are stuck with those rates, and we can't terminate until next year. And that big bummer. That's a horror story. Another horror story is I had a client where sometimes the payer has language that says, we're going to pay your contracted rate or 60% of your bill charge, whichever is less. It's actually standard contract language. Now, let's think about that, Matt. you have to make sure that your charges are high enough to capture your rate.
Yeah.
Uh,
Yeah.
So, I mean, we see this all the time, even when it's not 60% of your charges. When we do assessments, we find that have rates that are higher than their bill charge. So you really have to watch that. I think that when we quantified it, it was like $245,000 loss for a year with this particular payer because their charges, 60% of their charges was less than their contracted rate.
Yeah. Yeah.
Yeah.
Wow. We always talk with our medical billers to say when you get paid at 100% on a claim, that is not cause for celebration. That means something's wrong. And yeah, we need to fix it because, yeah, to your point, like it's got to be more. The insurance companies will happily pay you the lesser of the two, and they won't write it out to you either. So yeah,
Right. And I think a lot of people just the other thing that's really difficult is that that language is not in the rate exhibit in some agreements. It is buried in another place. So
Yeah.
if you get paid rates, like that's kind of easy to spot. But if it's 60% less, that's even harder. And it's not in an intuitive place. So, ugh.
Yeah.
Good. Let me see. I have so many horror stories. Another horror story, let me think here, could be, I mean, I have a lot of like, we get engaged and then we like figure out how to fix it, but mostly language. Oh, here's a horror story. Had a client that was working with a payer, and the payer would not budge on this language, most favored nations language. And luckily, we were able to catch it and review that language with the group, and they are not going to be participating with that particular payer because most favored nations language means that you can't have, they have to have the best rate from a contractual perspective. So it's kind of another near miss in that if you sign this, what it said was that the payer could go back and examine those claims and then take back those dollars if they were paying more than other payers. So it could be really dastardly. I mean, here's another really, it's a crazy story. You can't make these things up. I'm just remembering it now. There's a group that we worked with, and they negotiated a rate with a major payer. Well, the major payer paid them incorrectly for years. And when we went back to the table to renegotiate it, they realized it. They were literally one digit off in a button that they pushed on the payer side, with the tune of $800,000 is what they were saying the group owed them.
Oh, they had overpaid by their own error. Wow. Okay. Yeah.
Yeah. So it's like the message is make sure that you know what you should be paid and make sure that that's what you're being paid. And if you're being
monitoring
more, just understand that those takebacks can happen. And yeah, that's a true story.
Yes, absolutely. And there's so many great technology tools out there now that if your practice management system doesn't do that audit and spot check for you, there's so many great tools out there now that do. We have a client here that uncovered, she plugged in one of those contract monitoring tools recently and uncovered an underpayment from one of the plans that she'd executed a contract with them a few years ago, and they had never loaded the new contract. And so they were paying her at the old rates for 2 or 3 years. And that was a 6 or 7 figure adjustment. And she's still working to get that out of the insurance company.
Yeah, we do see that happen. I have a couple clients that are facing that right now. As a matter of fact, one that had not paid someone incorrectly for 10 years. And here, the punchline is they'll only go back, they only would go back 18 months. So it's on us on the practice side to identify and report that.
Yeah, that is a great thing to share with our audience is that, ignorance is not a defense. So you can't, and you'll only go back so far. I've said many times, the timely filing is 90 days, and the insurance company's ability to recoup money is 90 years. So like, you can go back. Well, how about some? I love the horror stories. We could probably have a whole conversation about that. How about some big wins that you've been able to achieve for your client?
Yeah. Thanks. Yeah. So, big wins. I was actually at a client yesterday. It's a large FQHC, and we've been working with them for about a year on their contracts, and we were able to increase them to the tune of $1 million, which was pretty good. Yeah. And yeah, so it was really awesome. They're doing such amazing work in the community, and it's yeah, such an honor to work with those kinds of organizations. And a lot of those, it's our strategy is pretty comprehensive, so it's working with lots of different payers, and yeah, so that's a big success story. That's pretty recent. Other one, actually, just yesterday, one of our analysts was looking at a proposal from a payer. It's taken us about 18 months to get here, but the pickup in it, a contract that's going to last 3 years is about $3 million. And this is for a clinic that is serving a very rural population. So again, kind of they're really in a kind of a desert, if you will. So, but a lot of hard work and a lot of meetings, and we were able to get a significant increase for them as well. Another one and this is just you just got to understand when you're negotiating contract, sometimes it doesn't start until you terminate. So we have a contract that a client terminated. They were being paid probably about 30% less on this contract than they were any other payer. And in our capacity, I mean, it takes you 8 weeks to get into this place.
Yeah. Yeah.
They gave the payer lots of opportunity to come to the table, and the payer gave them like a 1% proposal, 2% proposal. It was just not even worth, it was looking at really. Yeah. And they terminated the agreement, and right before the payer needed to pull the trigger with all of their processes for notification, they came back to the table, and I actually just got the email before we jumped on this call, but they came back with like an 18% increase, which is, I don't know, $134,000. So it definitely going to stop that termination. So that's a big win because it's a win for the community.
Absolutely.
Yeah.
My notice over the years is that in attending conferences and listening to smart people like you who do this all the time, is that they're on the East Coast of the United States, it was more general practice to term contracts in order to start a negotiation. And I remember hearing that, 5, 8, 10 years ago, and thinking, oh, out here in the West, we're, we're either a little bit more scaredy cat or we're more polite, but we don't term contracts to start negotiating. And now I'm starting to see it happen here in the Pacific Northwest and on the West Coast with our clients here. So I think that's it is an important, tool in the toolbox to notify the payer, hey, we're serious about this, and actually, you need us more than we need you. So, kind of give them that opportunity to figure that out.
Right. And always having the door open. I mean, we never want to terminate an agreement. However, stay in an agreement where you're not being paid what it costs you to provide the services is untenable. So, we just we just want the payer to pay market rates. So,
totally. Yeah. Well, and you bring up an important point too. We talk to a lot of groups that haven't calculated their cost per RVU. So I think that's a super important metric for all practice owners, administrators to be very familiar with. For your practice, how much does it cost you to generate that RVU of service before you pay your clinician? You need to know that before you're going to go into contracting, because if the answer is 40 and you're getting offered a contract at 38, I always like to joke, you can't make that up in volume.
Yeah.
And every one, it's going to keep people living. Wow.
Absolutely. That's a great point.
Yeah. Well, I'm glad you mentioned FQHCs, because I wanted to ask you about when you think about contracting. I know there are a lot of smaller clinics, FQHCs, maybe other not-for-profits that might just sort of shrug and go, is it really worth it for us to go through all this rigmarole? And like you said, 18 months, it takes a long time. And are we really going to get anything out of the profit?
Yeah. It's really amazing how practices end up feeling like they're dead in the ditch before they even start the process.
Yeah.
And what I'll tell you is that in our book of business, we have even solo practitioners. And I think the way to think about it is from a payer spend perspective, it's not all that difficult to give someone an increase when it's a smaller practice compared to a large system, for example, or a facility. That's one way to think about it. And on the FQHC side or rural health clinics, if you've got commercial business, definitely worth negotiating because those are paid in a completely different way. Many of those agreements are fee for service. And we have great success in assisting those clients. It's really powerful because when you're in those outlying communities, if you don't, your options are to go to the emergency room or to go to the clinic. And we all know that the cost of care is exceedingly high in the emergency room setting. So by supporting these providers that are in these rural communities, we are just doing great things for everybody. And it's good for the payer. I mean, it's reducing the spend. It's good for patient satisfaction. So it's kind of like when you're going to the table and you're an FQHC with a payer, helping them understand the community that you're serving and what the alternatives are. Because on the payer side, I'm from the payer side. So you're talking to me. I'm running 1,000 miles an hour. And when you have me on a call and you're showing me about your practice, I'm slowing down. I'm listening to what you're saying. I'm looking at the map and seeing all the dots in these rural communities. Something happens, to reps when they really start to see what's going on and all of the things that you are doing from a cost of care perspective to care for these communities.
Yeah. That is a great point. And I recall in your presentation at our recent financial management conference, you talking about how to kind of put your best foot forward when you're visiting with the payers. So could you expand on that a little bit? Like, what should groups be sharing with the plan?
Yeah, that's a great question. So first, I think sharing with the plan a little bit of what we think about are the nuts and bolts. So a lot of times we think, the payer understands all the services we provide. They know how many clinicians are here and how many locations and the services we provide because we send in the claims. The rep's has no idea. I was on a call with a major payer in a practice, primary care practice, and we were talking about the services they provide, and they do these injections for carpal tunnel that, potentially saving a surgery. I have no idea that this is going on. So just the nuts and bolts. This is how many clinicians are in the practice. These are the services that we provide. And by the way, this is the value. Calculate your value. So you can look up lots of transparency sites out there now. What does it cost for carpal tunnel surgery in this market? And you know what your cost is for the injection. So you could do a little bit of quick math and say, well, we think we're saving you about $500,000 a year. And we're asking for an 8% increase. So, do you want us to keep giving you money? Because we'd be happy to, or we could be referring these on to the hospital setting, which is not good for anybody. So I think making those connections is really important at the practice level. Here are the things that we are doing that they're increasing patient satisfaction. They are decreasing costs. They're increasing quality. And also they're not burning out physicians. It's really the quadruple aim. So all of those things together. So I think about it in those ways. Another thing to make sure that you're talking about with payers are what it costs you to provide those services. Jill, as you were just saying, what really does it cost you? And then what's happening from a market perspective? Everyone's a little different, but we like to cite, costs to retain staff have increased by X amount. So if you're asking for a 10% increase, for example, you can be sharing, we've had to pay our medical assistant 8% more. Our cost for technology has increased, all of those things, because when you are very detailed with those specifics, it's like they know you've done your homework. And really on the payer side, they see the same thing. So it's all these things are expensive. So share that information as well. Also share ways that you believe you can collaborate with the payer because we want a partnership, right? I mean, we all want the same thing. Payers are interested in providing healthcare. That's how they make their money, right?
Yep.
Through the network. And then we are providing that care. So what are ways that we can collaborate? We like to ask them what their initiatives are. What are things that they're working on? I was on a call recently with a group that's doling out diabetic eye exam. That's an initiative, particular payer. They were super interested in that. I had another payer that was working on mental health. And so this particular group was has therapists in schools. So it's like we're always trying to connect with each other. Like look at the website, identify what is happening on the payer side that you are working on as well, and bring those things up and see if there are ways to collaborate. So those are the main things that I would bring forward. The other thing I'll say is stories. I'm actually preparing a talk right now all about stories because it's proven that facts people do not remember. I mean, you can cite all kinds of things, percentages, some of the things I just talked about, but people will remember a story. So what we like to do in negotiations is have a clinician tell a story, a patient story, and it's really powerful. And reps remember those kinds of things. I remember those kinds of things. I remember visiting a client, a mental health provider that provides healthcare to women who are postpartum. And I walked into the office and I was supposed to meet with the CEO, and the CFO greeted me. And the CFO said, "I'm so sorry. She's not going to be able to meet with you today because a mother was just about to step in front of a train. And so she is triaging her. We're going to get her inpatient and she is dealing with that." And I'm like, well, heck yeah, she is. And this is I'm just like so honored to be working with an organization that does this kind of work. So I will never forget that moment. So, I mean, we're all like that. It's the emotional stuff that really for us, it ignites action. So look for those ways to ignite that. And usually it's a clinician because they are closest to the patient care.
They have the patient stories. Absolutely.
Yeah.
That is a wonderful just comment about how to relate. I think frequently when we go in, there is some animosity, as you said earlier, or there's just not really a relationship. It's sort of this, transactional thing, but there isn't really, connection, as you say. And the stories, absolutely so powerful. And I love seeing the clinics where they've paired the administrator with the clinician, and like you said, somebody who's going to own the process. And that really kind of is the power of that synchronicity between the two. It's really, really amazing to see. Yeah. So we could talk a lot about storytelling. So like our horror stories, we have a lot of those. Right? We can. So great. Well, let's shift gears a little bit and talk about the narrow network that are coming up, and the clinically integrated networks and the ACOs, all the alphabet. And what would you say to the audience about how best to navigate those?
Yeah. That's a great question. And our recommendation is to really kind of stand back and try to objectively understand the value of the network. I'll give you a little story. I had a client approach me yesterday, and a clinically integrated network is approaching him and his practice, and he's got a giant practice in this market, primary care, and the clinically integrated network is telling the group that they can improve their contract and piggyback on these value-based programs, but they want to do it on contingency, meaning if they get them a 20% increase, they're going to keep like 5% of that increase. So what we started to talk about was, well, let's think about that for a minute now. What happens if something changes? Nothing ever changes on the payer side.
Right.
Yeah. So every day on the listservs, we read about a policy change or something that's happening, a new CPT code, issues that are bulletins that are methodologies, groupers that are changing, things that are eroding our revenue. So, we talked a little bit about, what that might mean for the group. And they're definitely not going to move forward with that because it's just too dangerous and too volatile. So you really have to ask the question. And I like to think about it from like a lean perspective, like what is it, the A3, where you keep asking why? Like, okay, what happens if this? Then what happens if that? So walk down that path and get those questions answered. And be very wary if someone can't really give you an answer or gives you a non-answer. I was actually on a call earlier today with a group where they are exiting one clinically integrated network and they're trying to decide what they want to do next. And they had a network approach them that is not clinically integrated. And they said, well, sign on with us. We're working on it. We are going to have it done in a year, maybe two, and just trust us. So, we have to stand back and say, okay, does this really make sense for the practice? How do we know if this is ever really going to happen? So it's just like you really have to take the emotion out of it and the politics.
Yeah.
So it's really kind of in all of these arrangements, just understanding what's the value that you're getting and also what are you paying for. I have so many clients where they're in these and they don't even know what they're paying for. And we get to the bottom of it and they're paying something. And then also there's some sort of withhold. And then there's this other fee that's being paid. And you got to add that up so that you understand, is the juice worth the squeeze? And am I really getting the value that I want here? So with these networks, I think it's just important to be very curious, to get things in writing and to ask those questions and seek clarity. These are people just trying to do a job, but they should be able to give you that information so that you can educate yourself in your practice and make sure that you're making the best business decisions that you can.
Yeah, absolutely. Great advice. Well, and we run into groups where we're talking with them and it's clear that whomever is in charge of the contracts does not really understand the underpinnings of it and does not really understand the RBRBS system and how the math actually works. They are literally looking at a printed contract rate, in an exhibit and saying, is that higher or lower than last year? And it's kind of, there's no, yeah. And frequently we'll see it if the groups have attorneys negotiating their contracts. If the attorney doesn't understand the underpinnings of the math, they too are really focused on the legal construct of it and all the language and getting the contract. So you'll get a tight contract, but perhaps not fully plugged into all of the math that's running in the background. So
yeah, we see that too.
I bet you do. So I'd love to hear you talk a little bit about sort of the notion of, DIY versus outsourcing to a company like yours and how you see that working.
Yeah, I think that if it just depends on size. Like we find that if there are groups that are big enough, I mean, they're going to have someone who can negotiate contracts and they're going to have them as part of their team.
Yeah.
Perhaps revenue cycle lead is also skilled in this area. But smaller groups have it a little harder in that the skills that you need to kind of weave through the maze and understand all of the pieces are, it really takes someone with a lot of experience. And the DIY, I mean, I have another little horror story where I had a group where they were negotiating a rate. It was actually the physician that was doing the negotiation. She didn't understand modifiers. So when the payer sent her a sample fee schedule, it was the CPT code without a modifier with the rate. She thought that was the rate. But what she bills is with the 26, a professional component. So she was way off in her math.
Yeah.
So these are the hazards of the DIYs. It's like anything else, if you are not doing it on a routine basis, you might not know the nuances. So yeah, so those are if you're going to DIY it, and we really do recommend everybody try to negotiate their contracts. Make sure that you have some assistance, whether it be someone who's pretty savvy in the revenue cycle or get some outside help that can be a guide for you, because there are lots of gotchas in these contracts. Sometimes it's in the language. penalty. We see penalties all the time in language, and it's something that many times you can get removed. So if you're DIY, you also have to create the space and time to really read the agreements and understand what you're signing. So that's another piece. Is a lot of times we see these things get signed, but they don't even get read.
Yeah.
So those are the hazards. So it's like it's tough, because if you're going to DIY it, you need to make sure that you have the skill level necessary to understand the language and the rates. And if you do, you can definitely be successful. But if you don't, what we see is just, I can speak for Prosper Beyond's perspective. I mean, the ROI is amazing. So it more than pays for itself. And then also most of our clients become long-term clients because you can go back and get incremental increases.
Yeah.
It's just that we don't have time to do it. But saving up for a big bang every 10 years is, you're not going to get as far. So it's better just to go routinely back to payers and ask for those increases. It's a line item in their budget.
Yeah.
But the squeaky wheel, you've got to be in the queue to get those raises.
Exactly. Wonderful. Well, thank you so much, Doral. I have to say how much I appreciate your expertise and the way that you share that in the industry, the many speaking engagements that you do, and all of the energy and effort that you bring to bear for your client. So thank you very much. Thanks for being here today.
Yeah. Great to talk with you, and appreciate the opportunity, and good luck, everybody.
Likewise. Thanks.
Thanks.
Code Mastery. Unlock your revenue. Get paid more, reduce coding headaches, and win the coding game. Code Mastery is a program that is designed by physicians for physicians. Commit a small amount of time and effort to learning how to master the coding game and make a huge impact on your bottom line. Information is available at www.healtheps.com.